Okay, so this is about also about the so this is the tyrosine. From here we can start that how the synthesis of the tyrosine occurs, how they convert it into the norepinephrine, and then how they're released is same like that of the acetylcholine, same like that, and then how they are reuptake by the alpha 2 receptors, how they stimulate. So from here we can start. And in the cholinergic neuron, the amino acids, there is the choline, it comes to it enter into the cells, to the sodium transporter, and it attaches to the cholesterol CoA. Here, the tyrosine again enter into the neurons, and here it's converted into dopa, and dopa then can convert it into the dopamine. The dopamine then just enter into the vesicles and form the norepinephrine, and the norepinephrine, whenever it comes to infuse with the neuroterminal, it releases the norepinephrine into the synaptic vesicles and the synaptic cleft, where it releases this is attached to either to the alpha 1 receptors or to the beta 1 receptors. And if the alpha 1 receptor, this contraction of the smooth muscles may occur. If it is the beta 1 receptor, it can cardiac stimulation may occur. And if this is the beta 2 receptors, so maybe the effects will be on the lungs, right? And if there is a G uptake to the alpha 2 receptors, so they will diminish the effects of the norepinephrine here in the, so they will decrease the amount, the concentration of the norepinephrine here in the synaptic vesicles. As a result, what will happen? The sympathetic stimulation of the sympathetic activities may be diminished if it is attached, reuptake by the alpha 2 receptors. They are used again. It's used by the mechanism is the chem inhibitions. There are certain oxidized enzyme monoamine oxidases and catecholamine or transferases. They can inactivate these enzymes, these neurotransmitter into inactive metabolite. I will discuss that later on. So this is the net synaptic cleft. These are the sympathetic effector organ. The effects are the cholinergic receptors effects. So that's so it can also be best explained here. The sympathetic nervous stimulations. Distribution of this point. This is very important. You must know that where is the alpha 1 receptor, where is the alpha 2 receptors, where is the alpha 3 receptors, where is the beta 1, beta 2. You must remember. You must memorize that on the fingertips. That you must know that where is alpha 1, where is alpha 2 receptor, where is beta 1, where is beta 2, and other receptors. That's what is really, huh? That's the fingertip by the alpha 1, coronary vessel, cutaneous, veins, internal sphincters, iris, and dilator muscles. They are located here. Similarly, the alpha 2 presynaptic membranes, pancreas, vein, adipose tissue, GAT, sphincters, salivary glands. Beta 1, heart, SA node, atrial muscles, AV node, ventricles, kidney, the juxtaglomerular apparatus, mostly here, the beta 1, and the adipose tissue. Beta 2, the arterioles, muscular veins, bronchi, muscles, liver, pancreas, uterus, and iris constrictor muscles. And the beta 3, this is the most adipose tissue of the brain. This is the distribution of the adrenergic receptors that can be found here in these organs and these tissues. I just make these slides for you people. This is very comprehensive. We must know that major effects mediated by alpha and beta adrenoreceptors. Remember, as I mentioned, if you go further into the classification of the alpha receptors, alpha 1A, alpha 1B, alpha 2A, alpha 2B, these are the various alpha receptors. But generally, we just call that alpha 1 and alpha 2 receptors. Alpha 1 receptor, these are the functions. They are the effects of alpha 1 receptor. If it is stimulated, vasoconstriction will be here, increased peripheral resistance, increased blood pressures, mydriasis, increased closure of internal sphincter of the bladder. And alpha 2 receptors, inhibition of the norepinephrine release, inhibition of the acetylcholine release, inhibition of the insulin release, as they were located at the presynaptic nervous terminal. So that's why whenever they stimulate, they will reuptake the norepinephrine. The beta 1 receptors, there's another, beta, there are three kinds of beta receptors, as I did explain: beta 1, beta 2, beta 3. Beta 1, heart; beta 2, lungs; beta 3, adipose tissue. Beta 1, mostly whenever it stimulates tachycardia, when occurs is a net shift related to the physiological functions, the physiological and pharmacological responses to tachycardia, increased lipolysis, increased myocardial contractility, increased release of renin. Beta 2 vasodilation, decreased peripheral resistance, bronchodilation, increased muscle and liver glycogenolysis, and increased release of glucagon and release uterine smooth muscles. These are the effects of beta 2 whenever we stimulate them. So, the post-synaptic is the alpha 1 receptor. Where it located? Post-synaptic over the peripheral skin and viscera, blood vessels of smooth muscles. So this is there. The most alpha 1 receptor located over here. Pre-synaptic of the adrenergic neurons, but post-synaptic and CNS platelets, fat cells. Right? This should be noted. In the pre-synaptic, it's adrenergic neurons, but in the post-synaptic, it's in CNS platelets and fat cells. They have alpha 2 receptors. And the beta 1 brain, heart, juxtaglomerular cells of the kidneys, also lipocytes and presynaptic adrenergic terminals, the beta 1 receptor located. And the brain skeletal muscles, the beta 2 receptors located in the brain skeletal muscles, blood vessels, and uterus, while the beta 3 receptors are located in lipocytes. We have also the adrenergic is the dopamine receptor, D receptor. They are also D receptors. They are for there also the D1, dopamine 1, and dopamine 2, and they are located in the brain, renal vasculature, and the beta 2 is located in the brain presynaptic terminals. As we have no concerns with this, the dopamine, we will discuss that in the psychiatric drugs are the drugs acting on the nervous systems, especially in the depressive drugs. So we'll discuss that there. Somewhere in the antiemetic drugs are acting on the antiemetic or emetic drugs. So we'll mostly rely on the alpha 1 and the beta, alpha and beta receptors. And this is the alpha 1 receptor stimulation. Whenever this is stimulated, alpha 1, these are the agonist potentiator. Adrenaline high potency stimulate the as compared to noradrenaline, isoprenaline, and the smooth muscle contraction may occurs. You can see the selective action of agonist, the alpha 1 agonist and the alpha 1 blocker. These are the blockers and these are the alpha 1 agonist. Noradrenaline, phenylephrine, methaxamine, cyrozolines, and xylomethazolines, dexazosines, phenoxybenzamines, these are the blockers, and phentolamines, trazosines, tamsulicines, and terazosines. These are the alpha 1 blockers. Alpha 2, adrenaline has lesser than noradrenaline effects and as compared to the larger than the adrenaline effects. Potency effects are higher than noradrenaline as compared to this. Affinity is higher. Smooth muscle contraction, neurotransmitter inhibition may occur. Clonidine, guanfacines, and minoxidil, alpha methyl dopa, uhambine, idoxaxane, and tolazolines, and valsines. These are the alpha 2 blockers. Beta 1 isoprenaline, higher than affinity is higher as compared to adrenaline as compared to the noradrenaline. Heart muscle contractions is the noradrenaline, isoprenaline, dopamine. Metoprolol, atenolol, these are the beta blockers. And similarly, we also have the beta 2 isoprenalines, a higher affinity adrenaline and noradrenaline, smooth muscle relaxations, salbutamol, buterol, biotin, isoprenalines. These are the anti-asthmatic drugs, and these are the blockers. Beta 3 isoprenaline, this is affinity same, similar to noradrenaline and adrenaline. And enhanced lipolysis. This is the these are the agonists that don't have antagonists, or blockers are not here, not reported so far. So we will just mostly focus on the beta 1 and beta 2 receptors stimulations. Types of adrenergic receptors, I did explain, but let me just revise the affinity. Affinity of the adrenergic receptors are, you can see the effects of adrenergic receptors. Other alpha adrenergic receptors, epinephrine, non-epinephrine, and there look at their affinity. Low affinity is compared as high affinity, as compared with the non-epinephrine and isobutyrenol. Similarly, beta receptors, high affinity for the isobutyrenol, epinephrine as compared to non-epinephrine. So they have beta receptor high affinity. Adrenergic agonist, they are also termed as sympathomimetic drugs. So you can see the sympathomimetic, the synthesis is the first step is the synthesis of norepinephrine. How? A hydroxylation of tyrosine is the rate limiting step. Tyrosine hydroxylation after the sodium transporter are here. They're converted into dopa, and dopa is then converted into dopamine, right? Uptake into the storage vesicles. The second step, and dopamine enter into the vesicles and converted into norepinephrine. Okay, so dopa and dopamine, they can be oxidized by the monoamine oxidases into inactive metabolites, and that can be excreted in the urine. This is one of the oxidizing steps of the dopa and dopamine. Release of neurotransmitter here, whenever stimulus comes, the action potential generated, they will stimulate the norepinephrine into the synaptic vesicles. As a result, it can attach into the epinephrine can be released into synaptic cleft, synaptic space, where it attaches to the to the receptors, either if this is alpha 1 or beta 1 receptors. So they will produce the intracellular responses. If alpha 1 receptor or beta 1 or beta 2 receptors, so they can have their own effects. And this is the alpha 2 receptor, the presynaptic receptor. This is the alpha 2 receptors. They are reuptake by the alpha 2 receptor. As a result, the concentration of the beta of the norepinephrine can be decreased. Transport into the vesicle is inhibited by, remember this is the transport of this vesicle reserpines. They can inhibit this here, the transport of dopamine into the vesicles. So they can easily be degraded by the monoamine oxidases. So the reserpine have their own effects. A release of neurotransmitter in place of calcium causes fusion of the vesicle with the it is same like that of the sympathetic acetylcholine. And this is mostly blocked by the guanethidine. Guanethidine, they block this vesicles releasing. So if the antagonist effect will be, they mostly block these effects. Binding to receptors, when a binding receptor, postsynaptic receptor is activated by the binding of neurotransmitters. This is the post and the presynaptic. Removal of the norepinephrine, mostly they are removed by these, the released norepinephrine is rapidly taken into the neurons. Reuptake is inhibited by the SNRIs, right? Cocaine and pyramine. This is the serotonin non-receptor inhibitors, something like that. We will discuss it in antidepressants, I think. We'll discuss it in the antidepressant antipsychotic drugs. Mostly this is the, whenever norepinephrine is here, they can be either oxidized by the COMT, right? Either by the monoamine oxidases here, it can also inactivate and reuptake by the alpha 2 receptors, and the COMT, the catechol-O-methyltransferase, COMT, COMT, they inactivate metabolites and can be released into the urine. So mostly the metabolism is initiated, norepinephrine is methylated by COMT and oxidized by monoamine oxidases. Monoamine oxidase, they oxidize these norepinephrine, while the norepinephrine is methylated by the COMT, catechol-O-methyltransferases. They will transfer the methyl group into the attached into this norepinephrine, as well as they will become inactive. So this is the synthesis of the norepinephrine adrenergic neuron, the norepinephrine and epinephrenes. Here, This is also another little more explanation of this adrenergic tyrosine uptake by this one. They converted these are the alpha-methyl dopa, alpha-methyl para-tyrosines. They convert the tyrosine dopa into dopamine. They're blocked by the reserpines. You can see norepinephrine displaced by, and this is displaced by norepinephrine. This is the effects, and this is the little more explanation of that what I did explain. So now we can get 12 power beta receptors, right? And this is the release of that cells. These are the blockers. The red one, the circles, they are blockers. Okay, so this is the varicosity of the noradrenergic neuron. Show the synthesis and storage of epinephrine. How they are a tyrosine. The story starts from here. Dopamine goes into the vesicles. Dopamine converted into norepinephrine. Right, the norepinephrine came out from the vesicles into this cytoplasms. It can be entered into the hair again to the vesicles, and they can easily be degraded by the monoamine oxidases that is released by the mitochondrion. And norepinephrine can be reuptake by the vesicles, synaptic vesicles, synaptic preganglionic neuron, and they can be easily monoamine oxidized too by these monoamine oxidases. And monoamine oxidases, and as a result, they can be formed, and monoamine can be reuptake by the can be easily degraded by the formed and monoamine oxidases that can be easily degraded by the metabolized by the liver enzymes. Here also they can be found effector cells receptors, monoamine formed, they can be easily degraded. This is the routes of degradation. There are also the routes of degradations, various. And these are the effects. Norepinephrine effects here, they can attach to the effector cell receptors, alpha 1 and beta receptors, beta 1 receptors. And this is the steps in the synthetic pathways of epinephrine and norepinephrine. Phenylamine, you can see the story starts from here. The phenylamine hydroxylases converted to tyrosines. You can see the structure. You see the differences between here. The phenylalanine and the tyrosine difference only have this difference. Hydroxyl group attached here, the para positions. Tyrosine oxidases comes and that they converted the tyrosine into the L-dopa. And L-dopa have double hydroxyl here, hydroxyl, the OH group here. Other functional group is similar. The aromatic amino acid decarboxylase, they just decarboxylation, remove other carboxylic group occurs, and the L-dopa is converted into the dopamine. So this is the structure. You can see the differences here. The L-dopa and the dopamine. Decarboxylation of whenever the decarboxylation of the L-dopa occurs, they are converted into dopamine. And the dopamine here they can be converted into norepinephrine by the dopamine beta hydroxylases. As the hydroxyl group attached here, so the dopamine is converted into the norepinephrine. And whenever the NHCH3, the methylation occurs, the N-methyl transperases occurs, that converted into the epinephrenes, right? So this is the structure differences. You can see the structure, though their effects are somewhat similar, but they show affinity, as I mentioned. Some have high affinity to the alpha-1 receptors. Some have lower affinity, high affinity to the beta receptors. So the difference is only the affinity of the affinity that shows by these neurotransmitter at the receptors level. Similarly, norepinephrine, and this is epinephrine. Classification: direct acting. These are the direct acting adrenergic agonist, right? These are the drugs: clonidine, dobutamine, dopamine, epinephrine. and various supertrenol, whatever, phenylephrine, salmeterol, terbutaline, oxymetazolines, norepinephrine, uh, midodrine, metaproterenol. Some drugs are very, epinephrine and dopamine, they are very. And direct acting, amphetamine, cocaine. Direct and indirect acting mixed agents, ephedrine and pseudoephedrines. They are the direct and indirect mixed. We'll discuss one by one. We'll discuss these drugs one by one. Direct acting, most adrenergic drugs, they have the various characteristics of adrenergic agonist. Drugs are derivative of beta phenyl thilamines. As I mentioned, substitution on the benzene drug or in the ethylamine side chain produce a variety of compound with various ability to differentiate between alpha and beta receptor and to penetrate the CNS. As I mentioned in the structure diagram, that various variations at various positions may determine the affinity of the receptor as well as the penetration to CNS. Two important structure feature of these drugs are the number one, the number and location of hydroxyl substitution on the benzene ring, and the natural of the substituents of on the amino nitrogens. And you can see here the structure. You can see the differences. Norepinephrine, as I mentioned, epinephrine, isoproterenol. Affinity for beta receptors increases as group on the amino nitrogen gets larger. You can see. group सेवा की बदलाने और the affinity सेवा the beta receptors. Whenever it larger, as I mentioned in the previous slide, the isoproterenol have high affinity in the beta receptors. So because they have high the amino nitrogens, the group functional groups and the amino nitrogens, as compared to their only one H, that's why they have low affinity, and this one have the middle affinity, this one high affinity, the beta receptors. While as compared to these ones, the phenylephrine and the ephedrines and the dopamine, you can see. Drug containing the catechol ring are shown. This is the yellow one. These are the catechol rings, catecholamine rings, right? The yellow one shows the catechol rings, catechol structure. What are catecholamines? That contain 3 to 4 dihydroxybenzene groups, such as epinephrine, norepinephrine, isoproterenol, and dopamine. These are the sympathomimetic amines. They contain these groups. These are called catecholamines. You can see here, as in the previous diagrams, these are the catechol rings. So this is, you can see the hydroxy at the benzene rings. So this is, they are termed as catecholamines. High potency and direct activating alpha and beta receptors. Rapid inactivation are metabolized by COMT cosynaptically and by MAO, monoamine oxidase entropy neuronally, by COMT and monoamine in the gut wall, by MAO in the liver. This catecholamine only have a brief period of action when given parenterally, and they are inactivated, ineffective when administered orally. So poor penetration to CNS are polar and therefore do not really penetrate into the CNS. As you know, the properties of polar, more water soluble. Remember this, that most catecholamines have some clinical effects like anxiety, tremor, and headaches that are attributable to action on the CNS. Though they have these kinds of, they are the clinical effects produced. That's why they are considered as the toxicities of these catecholamines. Non-catecholamine lacking the catechol hydroxyl group have longer half-lives because they are not inactivated by the COMT. Include the phenylephrine, ephedrine, and amphetamines. That is, amphetamines in some ice-mice. They are synthetic analogs. They are used in the. These are the poor substrates for monoamine oxidases, an important role of metabolic, and thus show a prolonged duration of actions. Increased lipid solubility of Many of them are non-catecholamine due to lack of the polar hydroxyl groups and permits greater access to the CNS. That's why they have their more main effects on the central nervous systems. Mechanism of action, direct acting agonist. These drugs act directly on alpha and beta receptor produce effects similar to those that occur following stimulation of sympathetic nerves and release of activity from the adrenal medulla. You can see example of direct acting agonists include epinephrine, norepinephrine, isopropyl, dopamine, and phenylephrines. These are the direct acting agonists. You can see the direct actions that stimulate the receptors here. The indirect action, they either stimulate here in the drug enhanced release of norepinephrine from the vesicles. Mixed action, either they will show effects here as well as here, both. So drug acts both directly and indirectly. So they're termed as mixed actions. So remember these 3 points. Indirect, as I did explain. So direct acting cholinergic agonist. By effector agon without interacting with the presynaptic neuron is a group. These agents are widely used in clinical practices. Epinephrine, these are the drugs, is one of the 4 catecholamine, norepinephrine, dopamine, and dopamine commonly used in therapy. The first 3 are naturally occurring neurotransmitter, and the latter is a synthetic compound. This one, dopamine, is a synthetic one. Epinephrine, norepinephrine, and dopamine. These are the naturally occurring neurotransmitters are found in the body, where dopamine is a synthetic one. And norepinephrine is methylated to yield epinephrine. As I did explain, the differences between the structure. Norepinephrine can convert to epinephrine. Whenever the norepinephrine is methylated, it can be converted into epinephrine, which is stored in the chromaffin cells along with the norepinephrine. Release about 80% of the epinephrine and 20% of norepinephrine. Mostly the adrenal medulla, 80% epinephrine is released by the adrenal medulla and directed into circulation. And epinephrine interact with both alpha and beta receptors, and low doses beta effects can occur, and high doses alpha receptors and the vascular systems predominate with high doses alpha effects. The vasoconstriction are the strongest. Low dose, the vasodilation effect. Mostly the effects will be the beta receptors there, and at high doses, they may be the effects will be on the alpha receptors, and it causes the vasoconstrictions. CVS for the cardiovascular system, it mostly action of epinephrine on the cardiovascular system. Strengthen the contractility of the myocardium, the positive inotrope, beta 1 actions, and increase the rate of contraction, positive chronotrope. Whenever we are talking about the contractions, so this is the positive chronotropic effects. Whenever the contractility, so it's a inotropic effect, positive inotropic, ions related to ion. Chronotropics, the contraction of the smooth muscles, right? Cardiac output increases. These effects increase oxygen demand on the myocardium. As a result, the heart contractility increases, the blood pressure rises, the cardiac output increases. So these are the effects. The beta 1 receptor on the kidney to cause renin release. Renin is an enzyme involved in the production of angiotensin II, a potent vasoconstrictor. So remember that whenever the renin increased, so a potent vasoconstrictor, the renin convert, this is an enzyme that convert the angiotensin 1 into angiotensin 2. And angiotensin 2 is a potent vasoconstrictor. So vasoconstriction kararazi, such a peripheral resistance by increased key, the blood pressure by increased key. That was the epinephrine beta 1 receptor effects on the kidneys. And mostly the effects are in the GC position, the juxtaglomeralar JG position, just juxtaglomeralar cells, where it increases stimulate. So as there is a net result, is the increased production of the renin. Renin convert the angiotensin 1 into angiotensin 2, a potent vasoconstrictor. Blood pressure by increased key. Epinephrine constrict arterioles and scans. mucous membranes and viscera, alpha. These are the alpha effects. Is the alpha receptor located in these muscles and dilate vessels going to the liver and skeletal muscles. While the beta 2 effects, these combined effects result in a decrease in renal blood flow. Both combined effects, the alpha effects and the beta effects, they decrease the renal blood flow. As a result, what will happen? Retention may occurs. Retention, the increase cumulative effect is increase in systolic blood pressure, coupled with slight decrease in diastolic pressure, 22 beta 2 receptor. Mediated vasodilation and skeletal muscle vascular bed. This is the, let me just explain this one. Epinephrine increases the rate and force of cardiac contraction. Infusion of epinephrine, pulse rate vessel keep per minute is 50 to 100. So it can increase, you can see, up to 100. This is the epinephrine effects on the pulse rate. Blood pressure frequency effect. This is the effects on the blood pressure, the systolic and this is the diastolic. This is the systolic effects, pressure is increased and diastolic pressure is decreased. This is diastolic. Diastolic pressure decreased, and systolic can be increased. Peripheral resistance, it can be decreased. Peripheral resistance decreased. Epinephrine decreased the peripheral resistance. So, the result, peripheral resistance decreases. Epinephrine, right? So, these are the effects of the epinephrine. Epinephrine causes powerful bronchodilation by acting directly on bronchial smooth muscle, beta 2. The action relieved all known allergic or histamine-induced bronchoconstrictions in the case of anaphylactic shock. This can be alive. That's why most of the epinephrine is used in the anaphylactic shocks. This can be life-saving. An individual suffering from an acute asthmatic attack, epinephrine, the asthmatic attack rash is severe. Epinephrine rapidly relieves the dyspnea, the difficulty in breathing, and increase the tidal volume of gases inspired and expired. That can increase. Epinephrine also inhibits the release of allergy mediators such as histamine from mast cells. That's why it's also used in the allergic. Hyperglycemia, epinephrine has a significant hyperglycemic effect because of increased glycogenolysis in the liver, beta 2 effects. Increase of glucagon, beta 2 effect, and decreased release of insulin, alpha 2 effects. Lipolysis is as a result, lipolysis through agonist activity on the beta receptor of adipose tissues, increased level of chem stimulate hormone sensitive lipase, which stabilizes triglyceride to free fatty acids and glycerols. Therapeutic use is most of their therapeutic use is bronchospasms. Kalam je bronchoconstrictions, it can the epinephrine is a drug of choice in the bronchospasms. Anaphylactic shocks, treatment of type 1 anxiety, including anaphylaxis in response to allergens. Cardiac arrest, whenever someone get cardiac arrest, दिल का अचानक बंद होना, इतने cardiac arrest हुई, उस वक्त सर like तिली को ICU की, like this is the last option that they inject directly into the heart, into the cardiac, into the cardiac muscles, so that the patient might get a positive inotropic effects. Local anesthesia, because they contain low concentration, this is very important. 1:1,000 lakh parts of epinephrine greatly increase the duration of local anesthesia by producing vasoconstrictions. Vasoconstriction at the sites of injection epinephrine also reduces systemic absorption of the local anesthetic and promotes the local hemostasis. If someone asks this question, and why epinephrine is used along with anesthesia, because it produces vasoconstriction and it can stop the release of the anesthetic drugs directly into the systemic absorption can be reduces. So as a result, it promotes local hemostasis. It can lead to the local hemostasis. Intraocular surgeries that can use is used in the induction of maintenance gases during the intraocular surgeries. Pharmacokinetics is a rapid onset but a brief duration of action due to rapid declinations. These are the epinephrine effects. Intravenous subcutaneous, poor nutrition CNS, aerosols, metabolites appear in the urine. In the outpatient setting, it's intramuscular. And emergency epinephrine is given intravenously for the most rapid onset of action. It may also be given subcutaneously by endotracheal tube or by inhalation. It is rapidly metabolized, as I did explain, by NO,